Dr. Ali Bozorgi, cardiac electrophysiologist, and very welcome back to our ECG Refresher. Today, we'll review the ECG of an 85-year-old lady who was brought to the emergency department by her children after experiencing a syncopal attack. She has dementia, so she couldn't explain her symptoms, but her children said she had fainted a few hours earlier. She has no history of taking beta blockers or calcium channel blockers. Before we go any further, I encourage you to pause the video and carefully observe the ECG. I'll give you an in-depth breakdown of what we are seeing in a few moments. The ECG shows a very slow pulse rate of 30 per minute with non-conducted sinus P waves. These are non-conducted sinus P waves alternating by these conducted P waves in a pattern of 3 to 1. The sinus P wave rate is about 100 per minute. The conducted PR interval, these interval seems to be constant and is 320 milliseconds. This is diagnostic of 3 to 1 AV block. The important teaching point of this case is to carefully consider the etiology of AV block. Whenever you see AV block in a patient's ECG, you should carefully search for sign of inferior ST elevation because acute occlusion of AV node branch following RCA can result in AV node block. As you can see in this case, we have ST elevation in inferiorly 2, especially 3, and AVF you have ST elevation, and in 1 and AVL you have reciprocal ST depression. This suggests that the patient is having an acute MI, myocardial infarction, involving the inferior wall of left ventricle. So the diagnosis of the patient is now inferior ST elevation MI plus 3 to 1 AV block. The patient was transferred immediately to catheterization unit where angiography showed a totally occluded RCA. You can see RCA is totally occluded at midpoint, and also you can see temporary pacemaker implanted in RV. She underwent primary PCI for the RCA and her ECG returned to normal within a few days. In summary, this case is a reminder that AV block can be a sign of acute myocardial infarction. If you see AV block in a patient's ECG, it's important to carefully evaluate the patient for other signs of MI, such as ST elevation or T-wave inversion. If you suspect MI, the patient should be transferred to the catheterization lab for urgent revascularization. And that's all for today. If you'd like to learn more about this case, please visit cardiocase.com and read case 12, elaborated upon by Dr. Hatami. Stay tuned for our next videos, where we'll discuss more ECG insight. Thank you for joining us, and until next time.